Hi guys, we're going to talk about chapter 30, and this is going to review atraumatic care of children and families. And you're going to hear this terminology quite a bit as we work through this course, really. So atraumatic care. So how do we define atraumatic care? This is chapter 30 in your book, and we're going to get started here. Atraumatic care is defined as therapeutic care that minimizes or eliminates psychological and physical distress that can be experienced by children and their families in our healthcare system. This concept is based on the underlying premises of do no harm. As nurses, we can decrease the child's exposure to stressful situations and prevent and minimize pain and bodily injury. So let's look at each of these principles and what are some of the suggestions of atraumatic care. So the first one that we're going to look at is to prevent or minimize physical stressors. That means pain, discomfort, maybe they're immobile, maybe they haven't slept really well for several days, they don't have that ability to eat or drink, or they have changes in elimination, right? Those are all going to increase our stressors physically. So how can we prevent or minimize that? We can think about using numbing techniques such as Emla cream or other techniques such as our Buzzy Bee. We want to make sure we're doing those comfort holds, that therapeutic hugging, which we're going to talk about here in just a little bit. We want to maybe decrease the noise. Maybe that means we need to move them a little bit further away from the nurse's station, or we need to quiet the monitors in their room. We can also implement some pharmacological interventions. We want to just remember that we want to perform some of these procedures as safe, but as quickly as possible to minimize that stress for the child and the family. The next principle for traumatic care is the prevention or minimization of that parent-child separation. Depending on the age of the child, remember those little ones, they're going to want to have that familiar face. You're a stranger to them. So how can we prevent or minimize that parent-child separation? And we can promote some real family-centered care. So what does that look like? So that looks like we can provide those comfortable accommodations for our families. At Children's Mercy, we have that Ronald McDonald House, right? It gets exhausting to try to sleep on some of those pull-out sofas that are in the bed. So maybe we're going to reach out to our social worker, our team, and try to make different accommodations where that parent and child may have some separation, but we can accommodate for that separation during bedtimes, nap times, things like that. Maybe we'll want to also offer our family a choice of staying for any of those invasive procedures. Sometimes just educating our family on what's going to happen, then we can give them that choice. Do you want to stay, or is that going to be too stressful for you to stay? It also might mean bringing or letting that child bring in a toy from home, especially if that family member cannot be there for some of the procedures. So allowing some of that separation, allowing some of that prevention to that separation is that second component or principle of atraumatic care. And the last one we can talk about is that promotion of sense of control. I'm sure any of you that have been in the hospital, it's like you lose a lot of your own control. The nurses are coming in and giving you meds. They're dictating when you need to brush your teeth or bathe or any of those things, right? You lose some of that sense of control. So how can we promote some of that back? We can maintain that child's home routine, right? If they get up and they want to eat breakfast and they want to relax a little bit before they brush their teeth, let them do that, right? It gives them back some of that control. If they have any security items, let them have those. Maybe that's going to reduce some of their fear. Again, it gives them back some of that opportunity for control. Empower that family by providing some education. Elicit their knowledge and then provide the education. And then help them know when participating in their own child's care is okay and is acceptable, right? So those three principles are huge when we're talking about atraumatic care. Prevent or minimize physical stressors, prevent or minimize parent-child separation, and promote some of that sense of control back. So again, what is atraumatic care, right? It's therapeutic communication. It's very goal-directed, it's focused, it's very purposeful. We can do therapeutic play, which can provide some emotional outlet or coping devices. Make sure we're educating, help that child, help that family understand the reasons for why they are hospitalized or the reasons why they have to go through certain procedures. And then parental education, again, engaging that parent as an active participant in their child's health care as a part of that team. Pediatric nurses must be vigilant for situations that can cause distress, and therefore we must be able to identify those potential stressors. Make sure we're reading those nonverbal cues, especially during some of those procedures that we have to do on our kiddos. So let's talk a little bit about the role of a child life specialist, especially when it comes to atraumatic care. So if you are at Children's Mercy, or even some of the school districts may have some of these child life specialists. Remember, atraumatic care is where we're talking about minimizing, preventing pain, discomfort, immobility, sleep deprivation. The healthcare facility or hospital is a very unfamiliar environment for the child and that family, and it can be very intimidating. Families may feel anxious, they may feel fearful, helpless, and have no sense of control. So how do we prevent some of those physical stressors on the child and their family? We can utilize that child life specialist. The child life specialist can decrease the child's anxiety and fear while helping improve and encourage that child's understanding and cooperation. This is a program to help prepare children for hospitalization and painful procedures. These are non-medical support people during medical procedures. They cannot perform these medical procedures. They are there to help support. They can utilize therapeutic play and activities to support normal growth and development. This might include handling some of the equipment, using dolls to show how that procedure is going to be done. They help teach and support with coping and pain management strategies. If the siblings need support, they can advocate for that child and the family. They are also very good at their job with grief and bereavement support. We put our kiddos through numerous diagnostics and therapeutic procedures. So how can we prevent, remember this is principle number one, how can we prevent or minimize those physical stressors? We can engage the child in identifying what would make them more comfortable, right? If they're at an age, we can ask them, what's going to make you more comfortable? That's going to help minimize those stressors. Use positions that are comfortable to the child. And that might look like this. Front to front, or you might hear it called straddle, or you might hear it called chest to chest, right? You hold the child on the lap with their chest facing your chest, putting their arms around them. And again, that's a comfort hold to minimize some of that physical stressor. The next hold we can look at is back to front, where that child is sitting in the lap, they're seated on a table, and you're standing behind them, so the back is against your chest. You can hold firmly but gently, and making sure that we're praising that child after they've done a really well job. The next one is side sitting. So that's that just child sitting in your lap, and they can face left or right, depending on which extremity the nurse needs to get to. Again, a gentle but firm hold of that child's body. Cradle, this is usually done with infants. right? You're holding the baby in your arms, they're face up at you so you can talk to them, that you can smile at them. But again, you can have that really gentle, firm hold for that patient that's comforting for them to minimize some of those stressors. Other comfort holds that you might see are a bear hug or a swaddle. Sometimes those swaddles can also be called wrapping them like a burrito, right? We're swaddling them up really tight, which is very comforting for those infant children. So this is just a care card really directly from Children's Mercy. And when do you use those comfort positions? It talks to you there about shots, when we're placing our IVs, blood draws, if we're placing an NG tube down, right? We want to use those positions. Comfort positions really can be used anywhere, almost all the time. So exam rooms, outpatient labs, hospital rooms, procedure rooms, we can use those comfort holds. And why do we do this? Because the children prefer to sit up rather than lying on a table, right? If it's you or me, right, we would rather be able to see what's going on, but feel comforted when something invasive is going on. So the next thing we want to talk about is the use of distraction. When we use distraction methods, we can think about different techniques. So think about some of the techniques you might consider when we're doing distraction for our kiddos. So some of those might be pointing their toes, wiggling their toes, right? What happens when I say, okay, point your toes and wiggle them? Their brain automatically goes to that part and it kind of distracts them from what's going on. Squeezing your hand, counting out loud, singing a song. You'll notice if you're at Children's and we're doing some type of invasive procedure, lots of songs are being sang, right? ABCs, Twinkle Twinkle, whatever you want to sing, having the child sing along. Pointing at pictures on the ceiling, we have these great lights that go up on the ceiling that they can look at, blowing bubbles, playing music. I can remember vividly a little boy that we had, it's been a couple years ago, who really loved Bruno Mars, right? We all like a little Bruno. So Bruno Mars, we partied in his room with Bruno Mars, right? If he had to get blood draws, that's what the nurses were playing. That's what they were singing and dancing to, right? It was a distraction method for that child, and it worked geniusly. All right, so let's look at what happens before the procedure. We've got a task to do. We have a child patient. What are we going to do to help with atraumatic care before the procedure? The first thing we want to think about is decreasing anxiety. Whose anxiety are we decreasing? Right? We're decreasing the child's anxiety and the family's anxiety. When we have a child patient, it is not just the child we are taking care of. We are taking care of the entire family. So decreasing anxiety both with the child and the family. We want to promote the child's cooperation. That can come in the explaining what's going to happen, educating what's going to happen, right? Again, we've got to be aware of the developmental stage of our child. Talking to a 3-month-old is going to be a lot different than talking to a 3-year-old, which is going to be a lot different than talking to a 13-year-old. So where are they at developmentally, and how can we promote their cooperation with whatever we need? We want to support the family. We want to improve coping skills, talk through those coping skills that might help. We want to improve recovery, implementing interventions that are going to help with that. And we are always building that trusting relationship with our patient and building that nurse-patient rapport. When we think about during the procedure, we want to use a firm, confident, and positive approach. It really gives that family a sense of security. You're going to go into a pediatric patient's room, and it may be the first time you've placed an NG tube on a real patient, right? We've done it in lab, but this might be the first time you actually have a real human sitting in front of you. Go in firm, go in confidently, and you're going to have the sense of security from that family. Allow the child to express any anxiety or feelings, right? They need to express those emotions. This might be their way of communicating and coping. If you meet resistance from our toddlers and our preschool schoolers, which you probably will, it doesn't matter how much you prep them, they're going to resist you. You may have to use some alternative methods if you are unable to be able to perform your task. Being held down or restrained is very traumatizing, so make sure we're doing every possible atraumatic care that we can before we have to resort to that. And then older children, distraction can be very helpful during the procedure. After the procedure, hopefully mom and dad or the caretaker are there and they can hold and comfort that child. They can cuddle or soothe that baby. If they aren't, that's when that nurse can maybe step in and do those things. Distract with a toy or a puppet can help with play, especially if it's 7, 8, 9-year-olds, right? That might distract them from the emotionals or the emotions that they're feeling. We can provide older child to express those feelings, especially if they want to be comforted. A lot of times our 13, 14-year-olds need that comfort. Even though they're older, they still need to have those feelings expressed and comforted. And always remember to praise the child regardless of the response that they have given you. So general guidelines, any invasive procedure should be performed in a treatment room, not in that child's room. The child's room should remain a safe and secure area, right? They sleep there, they eat there, they go to the bathroom in there. So that space needs to be safe. So if we're doing something very traumatic, we need to take them out of that safe space so that when they come back into that room, it still feels like a safe space. All right, let's talk a little bit about family-centered care, right? This is a partnership between the child, the family, and the healthcare team. Family-centered care enhances confidence in the caregiver and helps prepare that child to assume responsibility for some of their own care needs. So where does this start? It starts with these core principles. We have to respect the child and the family. They may not always choose the choices you or I would choose, but we have to respect the choices that they do make. If they have any cultural, racial, or ethnic diversities, we need to recognize those and make sure that we're meeting those care experiences to what they are choosing to do. We want to identify and expand on any of the family strengths. This is really pertinent information. If we see a strength, we want to identify it and then we want to expand on it. Remember, we're supporting those family choices. We're maintaining some flexibility. We are educating them, right? That empowers them with education, honest, unbiased information, in an affirming, useful approach. We want to assist with any emotional or other supports, collaborate with families, and then empower those families, and education is the best way to do that. So if we have really good family-centered care, there's lots of positive outcomes that can come from that. Anxiety is decreased, children are calmer, and their pain management is usually enhanced. Recovery times are shorter. Families become more confident with their problem-solving skills. Communication between the healthcare team and the family is improved. There's decrease in our healthcare costs, and healthcare resources are used more effectively. So family-centered care is very vital for these positive outcomes. So the second principle, or another principle of atraumatic care, is that sense of control. Again, remember, if you or I have ever been hospitalized, there's been a couple of times I've been hospitalized, and you do feel like you lose a lot of your own sense of control. So patients and family can experience an extreme sense of loss. So how do we give some of that back? We can provide effective communication through education and obtaining necessary information and resources. Effective communication is critical in atraumatic care. It's the foundation of that nurse-patient relationship. If you've never had the opportunity to talk to children, it can be very challenging. But getting on that child's level, eye to eye, letting them warm up to you, especially if they are shy, and incorporating play can help them feel more at ease. Find a balance between neutral and affective communication. Remember, verbals and nonverbals are both forms of communication, so being aware of your nonverbals. Use developmental techniques for communicating with children, and then again, assess that parent and child's learning needs. Education can enhance and empower, which gives that family and that child back a lot of their control. Some specific learning principles that are related to children. These are pretty self-explanatory. Establish the rapport, right, with your child. That's the first step. We've got to establish that trusting nurse-patient relationship. Age and developmental levels are going to come into play. Create a teaching plan that addresses those developmental stages of that child. Adolescents are particularly sensitive about maintaining that body image, and we'll talk a lot about that next week. So making sure that we remember that body image is huge for that adolescence, that control and that autonomy are also two very key things with adolescents. So how do we improve learning? We can use several different techniques. We want to make sure we slow down and repeat information often. I feel like nurses get on this quick, like we're running around, right? And sometimes we just need to slow down. We need to slow down and repeat information often for some of those parents. Make sure we're sitting down with the patient and the family, because remember, they're in a foreign setting. So listening is going to be maybe the last thing they're doing. So speak in a conversational style, plain language, layman terms. Don't use all of the medical jargon. You can chunk information and teach it in small bites. Don't plan to go in and do a 30 to 45 minute conversation about NG feeds or PICC line antibiotics. Right, we might need to chunk that information so that they get the most important things first. And that's that next point, prioritizing information and giving the most important things first. Use of visuals can be huge. Drawing pictures, printing x-rays, that can really help solidify some information. Teaching using interactive hands-on approach, a lot of times that's that teach back. We teach them something and then we have them show us back using that hands-on approach. Teach using demonstration, return demonstration, and teach back or tell back. A lot of times in discharge, that's a great way. What questions do you have? What did you understand from the discharge? So that they're telling it back to you. And then we want to evaluate the learning. Can they demonstrate the skill? So at Children's, we do PCU, which is just that patient centered care, really. We kind of tell the parent, you're really in charge. Pretend like you're at home. We're just here as a backup for questions. But they have to actually be able to demonstrate all of the skills so that we know they're going to be capable of doing it at home. The child or family repeats back or teaches back the information in their own words. That's a really good evaluation. The child or family answers open-ended questions, or the child and family responds to a pretend scenario in their own home. So you can give a scenario. So if you get home and your child pulls out their NG tube, what is the first thing that you want to do? Right? Give them some scenarios. And then I think a lot of times nurses forget to document teaching. You should always document your education, right? If you don't document your education and that family comes back in 3 days and says, oh, nobody told me that, right? If it's not documented, then it's not done, right? So make sure you are documenting everything that you teach. What were the goals of the child education? Did that goal get met? What teaching method did you use? Did you talk about medications? Did you talk about diets or nutritional needs, medical equipment, follow-up care, right? We want to document all of that so that we can say we have told the parent all of this information. So when they come back and have questions, we can just reiterate what has previously been taught. And that concludes chapter 30. If you have any questions, we will chat a little bit about this chapter in class, and you can bring those questions to class. Thanks, guys.